Hi, everyone. Welcome to the critical role of the radiologist in the diagnosis and surveillance of patients with bronchiectasis. To introduce our faculty today, I am Dr. Ashley Lozier. I am affiliated with Yale University in New Haven, Connecticut, and I am a pulmonary and critical care physician.
Hello, I'm Mary Salvatore. I'm a thoracic radiologist working in Jacobi Medical Center in Bronx, New York.
Our learning objectives today will be to confirm the presence of bronchiectasis via high-resolution CT, determine how radiologic imaging can help determine the etiology and treatment course for bronchiectasis, and to summarize the needs of subsequent radiologic surveillance of patients who are diagnosed with bronchiectasis. An overview of this lecture will include an introduction to bronchiectasis, bronchiectasis diagnosis, suspicion and confirmation, CT procedure for bronchiectasis, role of imaging in identifying bronchiectasis etiology, role of imaging in bronchiectasis after diagnosis, and a case presentation. We will begin with an introduction to bronchiectasis. What is bronchiectasis? It is characterized by a radiologic appearance that may or may not be due to chronic airways disease. It has this permanent enlargement of the airways, and it is associated with a diagnostic code of J47.9 by ICD-10 coding. As I mentioned, this is a chronic respiratory disease, and it is associated with characteristic symptoms. It is not rare. The prevalence has been increasing over the past many years in the United States. Back in 2013, the U.S. prevalence was 139 to 213 cases per 100,000 individuals. And on the most recent reports, this has increased to about 478 cases per 100,000 individuals. And as you can see here on the accompanying images, the bronchus is bigger than the accompanying artery, which is the radiologic definition that will later be reviewed. When we look at the pathophysiology of bronchiectasis, it is commonly associated with these two images here on this slide, including the vicious cycle and the vicious vortex. On the left hand of the slide is the vicious cycle, characterized by bacterial infection or colonization, leading to neutrophilic inflammation, and subsequently going over to airway destruction and distortion, and then over towards abnormal mucus clearance. If we look to the right-hand side of the slide, this is a newer schematic, commonly referred to as the vicious vortex, which talks about this complex interplay of inflammatory causes and how it contributes to the development of bronchiectasis. To look at the role of inflammation in bronchiectasis. It is predominantly neutrophilic, where about 80% of patients have neutrophilic inflammation. But we must not forget that about 20% of these patients could have eosinophilic inflammation. The types of inflammation are important as these often help classify the clinical phenotypes. And neutrophilic inflammation is important even in those who actually have eosinophilic phenotypes. Alternative etiologies for inflammation may include the eosinophilic inflammation, but also the microbiome, as this can become important in determining the amount of inflammation and the frequency of exacerbations in patients. When we look at neutrophils, activated neutrophils are believed to be one of the key drivers of disease progression within bronchiectasis. As we think about neutrophils, they are a key component of the innate immune response, and excessive neutrophil serine proteinases, or NSPs, including neutrophil elastase, can contribute to bronchiectasis progression. And neutrophil elastase is required for the formation of neutrophil extracellular traps, which are all components of the inflammatory process of bronchiectasis. In the clinical practice of bronchiectasis, we're often left looking to determine what is considered a pulmonary exacerbation of bronchiectasis. And this is generally characterized as a worsening of airway and or systemic symptoms attributable to the underlying condition of bronchiectasis. This is classically defined as a bronchiectasis patient with deterioration in 3 or more of the following key symptoms for a duration of at least 48 hours, and this can include cough, sputum volume or consistency, sputum purulence, breathlessness, decreased exercise tolerance, fatigue, or hemoptysis. And at this point, a clinician will determine if a change in the bronchiectasis treatment is needed. So, for one of our first questions, or what do you know? A patient presents with chronic productive cough for the past 3 years. Which of the following would provide a diagnosis of bronchiectasis?
The diagnosis of clinically significant bronchiectasis requires clinical and radiologic correlation. Clinical signs and symptoms, you have to have two of them, either a cough for most days of the week or sputum production that occurs most days of the week, or a history of exacerbations. From a radiologic perspective, we have to have confirmation of bronchiectasis on chest CT with the airway to artery diameter ratio. Inner to outer airway diameter to artery diameter ratio of greater than 1 is diagnostic. However, we're more confident in our diagnosis with a ratio of 1.5 or greater. Also, there can be a lack of tapering in the periphery of the lung, and visibility of airways in the periphery of the lung are signs of bronchiectasis. Chest X-ray is suboptimal to diagnose bronchiectasis. The cystic changes can be hard to see in the tram track lines. These are much easier to see on the cross-sectional imaging, which is three-dimensional. But on the middle CT scan, we see cystic areas in the left lung apex and airway thickening in the left lower lobe. When should we suspect bronchiectasis? There's overlap with other pulmonary diseases, including COPD and asthma, so it can be complicated. And it can be part of a systemic or other disease process, such as congenital causes, autoimmune disease, immunodeficiency, gastrointestinal diseases like inflammatory bowel disease and gastroesophageal reflux. The answer is B, lack of airway tapering. Based on the international consensus recommendations, both radiologic and clinical criteria should be met for the diagnosis of clinically significant bronchiectasis as a respiratory disease. Radiological criteria include a ratio of our airway to artery diameters greater than or equal to 1, lack of airway tapering, visibility of airways in the periphery of the lung. It's important to do a good quality CT scan in order to diagnose bronchiectasis, especially when it's early and mild. The things we should consider when doing a chest CT scan, it doesn't need to be a contrast CT scan. In fact, a non-contrast CT scan is better because when patients get contrast, they feel warm all over and can become tachypnic. So a non-contrast chest CT scan, thin slices allow us to better see the wall. The slice thickness should be less than 1.5 millimeters. We're going to ask the patient to take a full inspiratory effort, and expiratory images also require instruction from the technologist so the patient breathes out completely to evaluate for air trapping. Let's review quickly the anatomy of the main bronchi. So on the right side, we have 10 branches of the right upper lobe right bronchus, and on the left side, there are 8 branches. In the right upper lobe, there are anterior, posterior, and apical. When I see the right upper lobe bronchus, I can't help think it looks like a goldfish cracker. The right middle lobe bronchus has medial and lateral, which is fortunate because the initials for medial and lateral are like middle lobe, M and L. For the branches of the right lower lobe, I think of it like a compass. There's a superior part, but then there is a north, like the anterior, posterior, like our north and south, and east and west are like medial and lateral. So 10 branches in total. On the left side, things are combined together to make room for the heart. In the left upper lobe, the apical and posterior segment are combined. So we have an anterior and apical posterior. There's no middle lobe, but the lingula has a superior and an inferior branch. In the left lower lobe, the anterior and medial components are combined. I think about that AM like a clock, and it has the same posterior, lateral, and superior elements, making a total of 8. How does imaging help in determining the etiology of bronchiectasis? Question number 2. A 52-year-old woman has worsening indigestion over the last 6 to 9 months, as well as persistent productive cough. Chest CT reveals diffuse basilar bronchiectasis. Which of the following is the most likely to be an underlying cause of this patient's bronchiectasis? CT features can be helpful for us to narrow down the differential diagnosis as to the cause of the bronchiectasis. For example, allergic bronchopulmonary aspergillosis is typically cylindrical or varicoid. It usually is in the upper lungs with a characteristic hand in glove appearance. In contrast, chronic aspiration is typically in the lower lobes with bronchial wall thickening and tree and bud consolidations. The radiographic description of bronchiectasis is described as cylindrical, the mildest form, where the bronchus is just bigger than the accompanying artery and very linear and straight. Varicose is the next degree of severity, and it has an undulating contour like a varicose vein. Cystic bronchiectasis is likened to a cluster of grapes with big cysts. If we were to do a VQ scan on a patient with cystic bronchiectasis, there would be no flow to the area where cystic bronchiectasis is located. So it's really not functional lung. Lynn Reed wrote an amazing paper about bronchiectasis in the 1950s. And she explained, well, in the normal patient, we have 8 conducting airways that are segmental. We have 8 conducting airways that are subsegmental, and we have 8 respiratory airways that are subsegmental, and then 2 distal sacs and ducts, for a total of 26 branches for the airways. What Lynn Reed showed is that in patients with cylindrical bronchiectasis, the mildest, earliest form of bronchiectasis, they still have those 16 conducting airways. She was using more crude technology, so she was only able to see the conducting airways and didn't describe the respiratory airways. She said there were 16. So there was no loss of airways with cylindrical. They were just dilated. Varicose bronchiectasis, she described there was some pruning or truncation with only 8 conducting airways. And saccular bronchiectasis or cystic bronchiectasis, there was further pruning to only 4 branching points as opposed to 16. So how do we approach radiology of bronchiectasis? I think first we can think about whether it's focal or it's diffuse. Focal bronchiectasis can be caused by a recent infection, a bacterial infection, a viral infection, or tuberculosis. In children, it's often due to a foreign body obstruction. It can be due to a bronchial stricture. Endobronchial masses such as carcinoid tumors can cause focal bronchiectasis. Broncholithiasis from a calcified lymph node eroding into a bronchus can cause focal bronchiectasis. And bronchial atresia from a congenital infection causes the bronchus to become narrowed, and there's air trapping surrounded. These are focal causes of bronchiectasis. Diffuse bronchiectasis is probably more common. When I think about diffuse bronchiectasis, I think about the bronchiectasis that affects the central airway. We said the airway branches from 1 to 26 times by the time it gets to the periphery of the lung. So diffuse central bronchiectasis is going to be more in the first branches. Kuhn's disease, we'll talk about, affects the trachea. And when we measure the trachea and it's greater than 3 centimeters in size, then we should think about Munya-Kuhn's. As the disease progresses, it involves the more peripheral branches of the airway, but it originates as dilatation of the trachea, with oftentimes diverticulum coming off the trachea. This is a very rare disease. I've only seen it 3 times in 30 years, so not very common. The next disease, when we think about central disease, is allergic bronchopulmonary aspergillosis, and that affects the 1st to the 4th branch. So it's very central as well. The bronchi become very distended, usually in the upper lobes. And then the clinical question that we should always ask is, do they have asthma or cystic fibrosis? If this persists and the mucus is not cleared, it'll become calcified and desiccated and look different on the CT scan over time. The next case is relatively rare. Williams-Campbell affects the 5th to the 8th bifurcation, loses cartilage. So you'll see normal central bronchi, normal peripheral bronchi, and in the middle they'll be dilated. If you do an expiratory CT scan, they'll collapse these dilated airways, confirming the diagnosis of Williams-Campbell. After we think about the central, we could think about the more diffuse bronchiectasis that affects the upper lungs. Sarcoidosis gives you bronchiectasis in the back of the upper lungs, typically in stage 4. Cystic fibrosis gives you bronchial dilatation in the upper lobes with mucus, and tuberculosis gives you the same distribution as sarcoidosis, bronchiectasis in the back of the upper lobes. If a patient presents with lower lobe bronchiectasis, chronic aspiration is something to consider. In this patient here, we see mucus in the right lower lobe bronchus, which helps to confirm our suspicion of chronic aspiration. At least 3 times a day, I see MAI infections. The middle CT scan shows dilated bronchus in the right middle lobe and the lingula, so classic for Lady Windermere syndrome. The patients who are affected by this are usually older women, and they're usually relatively thin. Desmodal cilia, I think about when I see a young male patient, maybe about 25 years old, who gives a history of recurrent infections. And then I look at the CT scan and I see that the bronchi are dilated and thick-walled in the lower lobes. And if the heart is on the correct side, then it's just desmodal cilia syndrome. But oftentimes the heart might be on the right instead of the left. And then we think about Cartageners. If the patient has yellow nails, desmodal cilia, then we think about yellow nail syndrome. Young syndrome is associated with azoospermia. So the broad category is desmodal cilia, but there's a lot of subdivisions of desmodal cilia syndrome. This is another very good example of a Lady Windermere syndrome. You can see the bronchi are dilated in the right middle lobe. We also see some dilated right lower lobe bronchi, so it's not always restricted to the right middle lobe and the lingula, and it can affect the lower lungs as well. It's hard to know how to follow this in some ways because it oftentimes progresses, and the treatment, I understand, is difficult. This patient has lower lung bronchiectasis. They're a younger person. We see the diffuse bronchial dilatation, mucoid impaction. That's very characteristic of desmodal cilia syndrome. So another important thing to talk about is air trapping. Oftentimes on CT scans, we'll see what's called mosaic attenuation, which just means that it's heterogeneous. On the CT scan in the right lower lobe, we see that medially there's some area of lower density. And we don't know whether that low density area is the area that's abnormal or the area that is next to it that is brighter. Is that the abnormal area? And what we do, we look at the darker area and see if the blood vessels are smaller in that area. If they are, then it's either small airways disease or pulmonary artery hypertension. If they are the same size as the whiter areas, then the white area is the sick area, and it's probably some ground glass, maybe inflammatory or infectious. So the blood vessels in this patient are smaller in the dark area. So an expiratory CT scan is done, and we see that there is more obvious heterogeneity of the lung parenchyma, which confirms that this is air trapping due to small airways disease. Question number 2, what did you learn? A 52-year-old woman has worsening indigestion over the last 6 to 9 months, as well as persistent productive cough. Chest CT reveals diffuse basilar bronchiectasis. Which of the following is the most likely to be an underlying cause of this patient's bronchiectasis? The correct answer is C, chronic aspiration. Chronic aspiration, such as in the context of gastroesophageal reflux disease, GERD, may be associated with a diffuse basilar bronchiectasis.
How can imaging help in determining treatment of bronchiectasis? Question number 3. A 32-year-old man with a diagnosis of asthma presents with dyspnea. A CT scan reveals central bronchiectasis with mucus plugging in a hand-in-glove pattern consistent with ABPA. What treatment would you recommend based on this diagnosis? When we think about bronchiectasis in the clinical setting, we often need to think about what are the goals of our treatments. Our goals are predominantly to relieve symptoms, to prevent or minimize progression of disease, as we know that oftentimes disease does progress over time in these patients. We want to prevent or minimize complications of the condition, including exacerbation, and overall improve quality of life. Our treatments for bronchiectasis are targeted at the underlying causes of bronchiectasis, and there is need for targeted treatments to be approved by the regulatory authorities for bronchiectasis, particularly when it's due to other causes than cystic fibrosis. So we're often left thinking back to what is the differential for the underlying bronchiectasis, whether or not it's conditions such as autoimmune conditions, or if it's potential genetic etiologies or inflammatory etiologies or immunodeficiencies. Then we're left looking at treating comorbid conditions such as GERD that has a very strong association with bronchiectasis and targeting the essential aspects of the underlying pathophysiology. Our therapeutic interventions are often targeted at multiple levels. First, when we think about mucus as one of the common symptoms that patients endorse of frequent cough with copious mucus production, are left looking at therapies such as airway clearance. Part of our airway clearance therapies are targeted at helping our patients overcome the mucociliary dysmotility that they have by helping them expectorate the mucus from their airways more effectively. We often use nebulized solutions such as hypertonic saline to help in mobilizing these secretions. Next, we're often left looking at therapeutic interventions for inflammation and nodules. Some of these nodules could be infectious in underlying cause. Particularly, we often need to focus on getting cultures to help guide our therapies. When we're looking at treating with anti-inflammatory agents, we're left thinking of chronic macrolide therapy for its immunomodulatory effects. It is really important before starting a chronic macrolide to obtain culture data, particularly to help exclude non-tuberculous mycobacteria infections such as MAC, as in those cases, we would not want to use a macrolide therapy as a potential therapeutic for bronchiectasis, as this could contribute to resistance if we need to treat the underlying NTM infection. Another common cause of nodules in these bronchiectatic airways includes chronic Pseudomonas infections. In this case, there is a body of literature that suggests that using suppressive antibiotics in patients who are frequent exacerbators may have some benefit in helping prevent future exacerbations and progression of disease. So, frequently, patients may consider nebulized antibiotics as an anti-pseudomonal agent to help decrease the amount of bacteria present in the lungs. Particularly, it looks at the density of bacteria within the lungs and how it decreases over time. And next, we look at the therapeutic interventions for distinct central bronchiectasis. As already mentioned, when we look at central bronchiectasis, we need to think about etiologies such as ABPA, which is often associated with allergic airways disease such as asthma. In these patients, we will often do some diagnostic testing looking for ABPA, which may include Aspergillus antibodies, and checking IgE and eosinophil levels. Particularly when we're targeting treatment for these patients who have ABPA or potential overlap syndromes, including asthma and COPD, we may look at using therapeutics such as inhaled bronchodilators and corticosteroids. And this can be in the form of inhaled corticosteroids, which are common medications used in pulmonary practice. Question number 3. A 32-year-old man with a diagnosis of asthma presents with dyspnea. A CT scan reveals central bronchiectasis with mucus plugging and a hand in glove pattern consistent with ABPA. What treatment would you recommend based on this diagnosis? The correct answer is A, corticosteroids. As we mentioned, because of the CT scan that is indicative of ABPA, corticosteroids are an appropriate treatment option. Bronchiectasis due to ABPA is an exception to the general recommendation to avoid corticosteroids in bronchiectasis patients. Because the underlying pathophysiology is driven by an allergic response, ABPA typically responds well to corticosteroid therapy.
What is the role for subsequent imaging? Which statement reflects recommendations or needs for CT scan imaging throughout the course of bronchiectasis? The reasons for subsequent imaging are many, which include surveillance, a response to see how the patient is responding to treatment. If the patient's symptoms are worsening, imaging may be obtained, and even for patient education, which has been considered very impactful. In this example, the patient had surveillance on the initial exam. We can see consolidation in the lingula from a MAI infection, which was found in the sputum cultures. And the lower images were obtained 6 months later, and we can see progression of disease with cavitation. Another example of a patient's response to therapy, patient with mycobacterium infection. Images are obtained after initiation of antibiotic regimen, and there's a marked reduction in the size of the cavities with near complete resolution of the mucus plugging and airway thickening.
When assessing disease severity in bronchiectasis management, the early recognition of severe disease is important as it often correlates with poor prognosis or high morbidity, hospitalization rates, and exacerbation rates. This can often facilitate clinicians to have closer monitoring of these patients, and it can aid in their treatment decisions, such as including long-term antibiotics, depending on if patients have airway colonization. In these patients, CT imaging is often recommended for patients when they have deteriorating bronchiectasis disease status or worsened symptoms. When we are characterizing the disease severity of bronchiectasis, we are often left looking at mild through moderate and severe disease severities. Particularly in mild disease, these are often patients who may have a lower number and intensity of symptoms, such as negative sputum cultures and perhaps only producing sputum during exacerbations. As we progress to moderate, these symptoms become more persistent, and oftentimes the patients may need antibiotics between exacerbations. And then lastly, in patients with severe disease, they often have chronic and large volumes of purulent sputum, reductions in their lung function on their pulmonary function tests. They may have frequent exacerbations, and they commonly may become colonized with bacteria in their airways. There are several radiologic aids to help in predicting disease severity, and these are sometimes used in clinical practice when helping guide the determination of disease severity and how it may potentially help determine those patients who are at high risk of progression or frequent exacerbations. One of the scales, called the Bronchiectasis Radiologically Indexed CT Score, or BRICS, is a devised or simplified version of the BALA scoring to help predict clinical severity. This scoring system can be used in idiopathic or post-infectious bronchiectasis patients, and particularly the radiographic CT severity of bronchiectasis has been associated with worsened obstructive deficits on spirometry. The scoring can range from 0 to 5, and this is largely dependent on the dilation or number of segments that are involved. In characterizing bronchiectasis, additional scoring systems do exist, such as the modified Rife score, which indicates the radiologic severity of bronchiectasis again. And this score includes the number of lobes that are involved and the degree of dilatation, whether it's cylindrical, varicose, or cystic, as we had previously reviewed. And this score is between 1 to 18, with those with higher scores having more severe disease. Particularly when we use these scoring systems, we're trying to classify or risk stratify patients at risk of progression of disease. And there are 3 additional scoring systems that can be used in clinical practice, such as the Bronchiectasis Severity Index, the FACED score, or the EFACED score. And these often do incorporate some of the radiologic parameters along with other clinical parameters. And they, again, help in assisting the prediction for the severity of bronchiectasis and those individuals at increased risk for exacerbations, hospitalizations, or mortality. Within the bronchiectasis patient population, there is a strong element of patient education to help in supporting treatment adherence. When trying to improve treatment adherence, factors that may help include informing patients on their disease progression, really educating them on reasons to do their treatments and the potential expected treatment effects, as well as the negative consequences of non-adherence and then feedback on disease progression. Sometimes in clinical practice, it can be helpful to review the treatment techniques such as airway clearance in detail, along with reviewing imaging and pulmonary function testing to help demonstrate the potential impacts of these treatments to the patients over time. Question number 4. Which statement reflects recommendations and or needs for CT imaging throughout the course of bronchiectasis? The correct answer is C. It is included in risk and severity scoring systems. As just reviewed, several scoring systems for assessing bronchiectasis outcomes, risk, and severity incorporate imaging criteria, including the Bronchiectasis Severity Index, the FACED score, and the BRICS scales.
Next, let's consider a case. A 56-year-old woman presents to primary care with bronchitis, including a productive cough and difficulty taking deep breaths. She had a bad case of flu 3 years ago, and she's had increasingly frequent and severe cases of bronchitis since that time. Her primary care physician prescribed antibiotic therapy. She's referred to radiology for evaluation of suspected pneumonia. Let's take a moment to reflect on bronchiectasis diagnosis. Where in your practice have you seen delays in confirming bronchiectasis diagnosis? This is the initial imaging of our patient. We see bronchiectasis bilaterally in the anterior lungs in the right middle lobe and the lingula, with bronchial wall dilatation and mucoid impaction. This location is highly suggestive of MAI infection. The bronchiectasis severity score is 5, and 5 to 8 indicates moderate bronchiectasis. Let's again reflect on inflammation in bronchiectasis. How often do you consider the potential impact of neutrophilic inflammation on disease status and progression in patients with bronchiectasis and persistent infection? The patient came back for a 3-month follow-up. The patient improved after appropriate antibiotic and started airway clearance therapy. Short-term follow-up in 3 months after initial treatment implementation, improved CT scan with reduced mucus plugging, also improved symptoms. Here we can see the follow-up imaging and coronal views of the chest CT scan. The patient felt relatively well for about 5 months and then started to have cough and feel tired again. She admits that she dropped off of her treatment because she felt better and was so busy. The physician requested a repeat CT scan, which showed increased plugging. So the first coronal shows the 3-month checkup where she's doing better. And then after 1 year, she's progressed without treatment.
When we're looking at this case in clinical practice, this is a relatively common interaction that we will have with some of our patients with bronchiectasis. Airway clearance is a very time-consuming treatment, and oftentimes as patients are feeling well, it is not uncommon that patients will decrease the amount of airway clearance they are doing or potentially even discontinue it. During our clinical practice, as pulmonary providers, we really must try to look at focusing in on the education of our patients, as we've previously alluded to, in trying to optimize patient adherence. Educating our patients on the importance of airway clearance and why it is needed to help prevent disease progression, rather than purely just alleviating symptoms, and in providing them input on their imaging progression or potentially their pulmonary function testing progression to help further support the reasons to do their therapies targeted at their bronchiectasis.
Another reflection, how often do you share CT scan results with patients who have bronchiectasis?
When we are looking at some of the takeaway points from today's discussion, we are left reviewing that radiologists need to be aware of the clinical characteristics of bronchiectasis as a chronic respiratory disease, so high-resolution CT can be used for the diagnostic confirmation. The recognition of these CT patterns of bronchiectasis can provide insights regarding the etiology and related treatment courses. In addition to the diagnostic confirmation, CT chest can be employed at different stages of bronchiectasis to help and assess disease severity and progression, follow treatment adherence and response to therapies, and educate patients on their disease and its treatment impacts.
Next, we'll speak about future directions in the imaging of bronchiectasis. Great strides have been made with regard to the treatment of bronchiectasis and the diagnosis, and continued strides in imaging are being made, including ultra-short UTE, and ZTE imaging using MRI. This tool is remarkable in that it's an MRI image, so it has no radiation, and it takes, instead of the typical longer period of time, only 2.5 minutes. The patient has respiratory gating, so the exam is only imaged while the patient is breathing in, so there's less motion artifact. And these image quality is excellent on this healthy person. Of course, it's going to be more challenging when someone is short of breath, but it's going in the right direction with its no radiation, short time, and respiratory gating. Functional MRI also is very exciting to see what happens in the lungs as the patient breathes in and out. With MRI, we're not limited by radiation dose, so we can get more functional data, which helps the pulmonologist make important decisions about treatment.
From the clinical perspective, these imaging modalities do help highlight the pre and post airway clearance changes that can occur. Where you can see on the top part of the images, this is prior to a patient using their airway clearance devices, which they were using positive expiratory pressure devices. And then on the bottom part of the images, it's looking at the post airway clearance devices. And as you can see, there is some improved ventilation, which correlates a lot with our clinical practice where patients are more effectively clearing their secretions to help improve their ventilation.
Thank you very much. Please complete the post-test and evaluation to claim your credit.